Yeah. Hi, thanks for everybody to join the webinar. And today we have the distinguished, urology surgeon professor at MGH, Dr. Dahl, to join us. I'm Wei Wu He. I'm the chairman of Human Longevity. So I'll brag a little bit by myself. I was a graduate student when I was involved in isolating the gene for PSA. So, I've been working on prostate cancer biology for almost 40 years now. And I'm always interested in prostate cancer prevention. So HLI, obviously has been doing this for 12 years. And so far we don't have, we treated about 5,000 men, and we don't have a single person died of prostate cancer, except the one gentleman came in with already late stage prostate cancer. So the ultimate goal, we are trying to do it at Human Longevity is no man should get to late stage prostate cancer. We are putting together algorithms that we can get a screening test, closer and closer to 100% sensitivity and 100% specificity. That's the elusive goal for cancer screening. And we recently made a huge pledge. This is not marketing. It's really, we're committed to this prostate cancer problem. For any member of Human Longevity, they're willing to stick to our protocol. If we ever missed that gentleman's late stage prostate cancer, we are putting aside $1 million for that particular client's, treatment and intervention of prostate cancer. That's kind of our R&D dollar for, our commitment for our, clients. So with that, I love to introduce Dr. Dahl. Dr. Dahl is the MGH trustee endowed chair in urology oncology. He is an internationally recognized expert in prostate cancer and pioneer in the development of minimally invasive surgery in prostate and kidney cancer. He serves as the chief of urological oncology at the Massachusetts General Hospital, Department of Urology, and the co-director of the Claire and John Bertucci Center for Genital Urology Malignancies. He is a panel member of the National Cooperative Cancer Center Network Guidelines Panel on Prostate Cancer Screening and Early Detection. He has published extensively on surgical techniques, translational science, and clinical trials. And he's an associate professor of surgery at Harvard Medical School. Let's welcome Dr. Dahl.
Well, thank you. It's really an honor and a pleasure to be with you all tonight. And I've had some excellent interactions with your organization over the years. And so I was honored to be able to speak with you all about a subject that I'm really passionate about, prostate cancer. Sometimes it's so controversial in so many ways, but I think it's so poorly understood in general. And I'm glad to see that you're so passionate about it, because I think there's a lot of important things that are not being done well that we need to do better. So one example just from the other day, looking through the New York Times, I'm reading Mr. Pels. He was a physicist. He worked at NASA, was a passionate golfer, and turned his scientific passion into figuring out how to hit golf balls at, any golfer, short game, putting, chipping, and just studied this so intensely and became one of the world's experts in this, coaching the likes of Phil Mickelson, had his own Golf Channel show regularly. Well, you look deeper into, he passed at age 85. His son says the cause was prostate cancer. Well, many people say, well, you've got to die of something. 85, that's pretty good. But, I unfortunately see so many men who are around the same age many of them are still working. Many of them are still passionate about their activities. They're deeply involved with their family lives. And yet, and so many of their other health issues are well managed that used to kill people at a much earlier age. And now we're seeing more and more men suffering and dying from prostate cancer because nobody looked, nobody screened, nobody cared, nobody thought it was important after they were 65 or 70. Well, prostate cancer does grow slowly, but if you miss it at 70, you can die at 85 of prostate cancer. And I just think that we're not doing things the right way. So big challenges that we have here. When you look, this is classic studies from autopsies. If you take men at lots of different age groups, so even men in their 30s and 40s, dying of other things, you look at their prostate. Prostate cancer is so common if you start piecing through their prostates, that even men in their 40s, a quarter of them may have some prostate cancer that you can find under a microscope. And there's always been this classic dilemma. If you can find some of these early cancers, are they so small, are they so slow growing that is cure really even necessary in those people? And in some people who have the more aggressive cancers, is it even possible to find it at an early stage and prevent their death? So is cure necessary in those in whom it is possible, and possible in those in whom it is necessary? Still pertains. I think it's better than it used to be. What this graph also shows us is a very significant difference in ethnic backgrounds. So let's just take, men 50 to 59. 20% of men already have prostate cancer who are of Caucasian background. Of African American background, close to 50% of them already have cancer. Now, fortunately for Dr. He and the other Asian groups, it's historically been less and less, but what we see with more modern life is we're seeing more and more prostate cancer in men of Asian descent as well. It still seems to be less prevalent, but it's becoming more and more common. And I spent a lot of time in China, and they've been learning about this and screening and treating, and it's been a privilege to work with them and help them become expert there as well. But so it's becoming an increasing burden. Now, if we look in the United States, prostate cancer is by far the #1 diagnosis of cancer in men. 30% of all cancers are prostate cancer. Now, that's why it's so common. Thankfully, most of them are not fatal, but still, it's the second leading cause of cancer death. So almost 36,000 men are expected to die this year of prostate cancer. That is a lot of men. That's about 10% of all cancer deaths is prostate cancer in men. And my way of thinking is that's too many. If you know anybody who's been one of those people, it's devastating. It's a terribly long, drawn out, painful way to go. Now, PSA, the blood test, was an amazing miracle. And there's really still very few cancers that have anything like that. And if we look historically, so in the light blue, PSA was discovered in the late 1980s, became widely used in the 1990s. All of a sudden, the number of prostate cancers that were diagnosed in the US skyrocketed, almost 2.5 times more than had been found before, because it was possible to diagnose prostate cancer at a much earlier stage. So many more men were diagnosed. And prostate cancers were recognized that just really previously were not found. Interestingly, eventually there seemed to be a little bit of fishing out the farm, getting to more of a steady state. But then there was this big drop, and we'll talk more about that, is when people thought maybe we're screening too much, and they stopped, the number of diagnoses went way down. I mean, kind of breast cancer is probably the most similar in many ways, kind of analogy. And over a long period of time, for the last 50 years, it's been pretty steady. But prostate cancer has had this amazing roller coaster ride of diagnosis over the last 50 years. And a lot of it is because of the PSA blood test. Again, when you look in the US, very significant ethnic differences in African American men. Almost twice as many men have prostate cancer as other other ethnic backgrounds. It's a really significant issue in this community, and unfortunately, we're not doing as well at finding that early in that group particularly. Prostate cancer is very curable. When you look at the number of people, currently, thankfully, most people are found at an early stage, either localized to the prostate or near the prostate in the regional area. And that's where you want to find it, because the survival rate, if you find it when it's already spread, is only 30% 5-year survival for men who have metastatic and distant prostate cancer. So if you can find it early, we can have a very good chance of curing people, keeping it under control. So, and what we found is, this looks similar to the other graph, but the number of metastatic cases that were diagnosed when PSA first became widely used plummeted. So the number of men that were discovered to have metastatic cancer went way, way down. So we're making those diagnoses at the earlier curable stage, exactly what you hope to do given what we know about this cancer. Always interesting to compare this to mammography. Well, I mean, look, it really hasn't seemed to have had a whole lot of change in the total incidence of metastatic disease, but PSA screening, huge impact on the number of men presenting with incurable level prostate cancer. And if you look at the survival rate during the time, so looking at early 1990s is when PSA first became widely used, the death rate from prostate cancer in the United States has gone down more than 50%. Huge success, fantastic. So we should all be happy. PSA screening and early diagnosis should be widespread. Unfortunately, there's been so much worry that we've been making too many diagnoses, that too many people have been getting treatments, aggressive treatments that they didn't need. There was a big pushback by the United States Preventative Services Task Force, and came out and strongly said to stop screening in 2008. And when you're looking at what the impact of that, and this is looking at different ethnic groups, so that the different colors here are different ethnic groups. So around 2008, a lot of primary care doctors stopped doing PSA screening because of these recommendations. And what do we start seeing? The distant stage diagnoses of prostate cancer started going up and up and up in all ethnic groups. Unfortunately, very steeply in the black men, but in Asian, non-Hispanic, white, and all groups, Asian and Pacific Islanders. Everybody is seeing more and more, after lots of good progress, unfortunately giving up that progress. So the increase of metastatic disease has gone up for the almost 7% in the past decade because of stopping screening, unfortunately. So it's very again, black men have a 2 times greater mortality than white men in prostate cancer. 1 in 8 men. So if you take that number of total men in the United States expected to be diagnosed this year, that's 1 out of every 8 men is going to be diagnosed with prostate cancer. 35,000 deaths. That means about 1 out of 30 men is going to die of prostate cancer. That to me seems like an enormously high number. That should not be the case. So of all cancers, again, 30% of all cancer is prostate cancer. So overall, screening has resulted in much lower death rates. But the interesting thing is, more than half of the men now that developed metastatic disease were initially diagnosed with early stage disease, meaning it wasn't treated as aggressively, or it wasn't, even then, it wasn't found as early as it should have been. So now we are seeing this longer tail of people who were diagnosed maybe 8-10 years ago, got definitive treatment, surgery, radiation, unfortunately wasn't cured. And now, it goes on for a long time. And some of these people are now dying of prostate cancer. Well, this is not just, a lot of data comes from the US, but when you look, this was recently published in The Lancet, amazing eye-opening paper that kind of assesses everything that we want to know about the global burden of prostate cancer. So in 112 different countries, prostate cancer is the most common cancer in men. accounts for 15% of all cancers. And they estimate that this year around the world, there are going to be 1.4 million cases diagnosed in the world. By 2040, 15 years from now, they estimate 2.9 million men will have prostate cancer diagnosis. So that's over twice as many as there are right now. Unfortunately, in a large percentage of even the well-developed countries, there are not good routine screening protocols. There is inadequate training. There is not enough resources to find the people at an early curable stage and to give them quality, definitive treatment. So 1.4 million cases now will be 2.9 in 15 years. Unfortunately, this is not related to lifestyle changes or public health interventions. Prostate cancer, unfortunately, is practically built into genetic destiny in men and a lot. The late diagnosis is very common, and we don't have the resources to find and treat these patients. There's not enough surgeons. There's not enough technology experience in radiation treatment to make a major impact. And so we're going to see more and more global burden of advanced prostate cancer, unfortunately, in the next 15 to 20 years. Genetics probably plays a significant role. This has been studied quite a lot, but there is a lot more to learn. Some of the common genetics predispositions to cancer that we're aware of, the BRCA1 or BRCA genes that are well known, I think, in women, some celebrities who've had mastectomies and their ovaries removed because of these genetics, because of their high risk of breast and ovarian cancer. Well, it turns out more and more we're finding out that the men who carry these are at substantially higher rate of developing high-grade prostate cancer. So the BRCA1 gene has about a 3.5 times increased risk of prostate cancer, with an absolute lifetime risk of somewhere from 15 to 45% of being diagnosed with prostate cancer. BRCA2 is even more significant, so 5 to 9 times greater incidence of being diagnosed with prostate cancer, with a lifetime risk of 60% of being diagnosed with prostate cancer. Now, I follow a number of these patients. Some men with this have developed both prostate cancer and breast cancer. And so these are a really challenging group. Clearly, you want to identify these people early for more intensive screening and careful diagnosis at an earlier stage. So we have a very active clinic for BRCA patients, but also some of the HOXB, ATM, other known genetic predispositions to prostate cancer, to really do intensive screening and try to make sure that we can catch them at the right stage and prevent them from having the more serious consequences. Well, prostate cancer is so common. This is part of the controversies. You may need to screen just completely asymptomatic men, anywhere from 500 to 1,400 men, to save a life from prostate cancer. That's considered a huge number in public health world to have to go through that many. And you have to treat, and there's been lots of controversy about that. So you have to find one out of every 500 or 600 men will actually be found to have cancer. You have to treat an awful lot of them because prostate cancers grow so slowly. To save a life, somewhere between 10 and 50 of them are getting treated who may not actually have needed to be treated to be cured and save their lives. There have been a lot of challenges. Prostate biopsy, no patient wants to have their prostate examined. Physicians don't want to examine the prostate. Prostate biopsy, the way it has been traditionally being done, has risks of infections, sometimes quite serious, with especially more and more antibiotic resistance being seen around the world. And then men and lots of people have a lot of anxiety related to evaluation and being found to have prostate cancer, the indignities of it, the worries about the possible side effects of sexual function and quality of life issues are really significant and a major barrier to people wanting to get screened. There's a lot of worry about their quality of life being ruined and questionable benefit. So as I mentioned, in 2008, the United States Preventive Services Task Force, which is hugely influential for the primary care community in the U.S., in 2008 went against and said you shouldn't do any screening. They modified that in 2012, and their current recommendation is that between ages 55 and 69, there should be an individual discussion based on conversation with their primary physician, talking about the pros and cons of potential harms of early screening. And they say, do not screen anyone over the age of 70. Now, I think this is terribly outdated. I also think the reality is that in the short period of time that most people have with their primary physicians, they're not going to have a chance to spend, if you have 15 or 20 minutes for an annual physical exam, there's so many things to talk about and so many issues to go over. Most people end up, reality is the primary doctor says, I don't believe in PSA screening, doesn't order it. And that's it. And unfortunately, I see far too many people who don't get screened or get a PSA and is misinterpreted by their practitioners. And time has gone on quite a long time before the clear diagnosis is made as it should. And again, there's a lot of men who are doing fabulously well at 70 and are going to live to be a long, healthy and productive well into their 80s and hopefully 90s. And to just stop screening, because some of these prostate cancers are serious, to stop screening, stop paying any attention to that at 70, I think is really, really not in keeping with modern medicine, and particularly men who are healthy and vigorous and have their heart health and their cholesterol and they're physically active and they're all these, I think prostate cancer is more of a burden to those men than perhaps the classic, average American male who may be 100 pounds overweight and has uncontrolled hypertension and diabetes. And, for people who are taking good care of themselves and cognizant of health issues and have excellent physicians, I think there really is a much bigger burden, and we need to think differently about that group. Again, unfortunately, we're seeing more and more what the consequences of not screening. Yes, the overall diagnosis in men 50 to 74 and 50 to 7 and over 75, the number of diagnoses since these recommendations from the United States Preventive Services Task Force went way down. Unfortunately, it wasn't, they were missing the serious cases. So the number of distant metastases in those groups has gone way up during that time. So they weren't just diagnosing the clinically irrelevant cancers, they misdiagnosing the serious cancers, and that's just shouldn't happen. Even within different organizations, and I don't want to belabor this too much, this American Urologic Association and the Society of Urologic Oncology has different recommendations. Sort of, they suggest, well, at age 45 to 50, you could start screening. Again, try to talk it over with the patients. Only screen every 2 to 4 years if the PSA was pretty low. There's not a lot of data to support these recommendations. The panel that, as I mentioned, that I'm on, I think we do the most thoughtful analysis, which is for age 40 to 75. Men should get at age 45 some baseline, and I think that the more data you have, the better, because what's happening around 45, men are starting to develop benign prostate enlargement, and that's one of the big confounders of PSA. Is the larger the prostate is, well, in general, the more PSA is. So if you start screening men earlier before BPH becomes an issue, you're just going to have more data points. You can see trends and curve lines that can really be very helpful. Again, it should be more individualized, more intensive, focused on men with known germline mutations, men of African descent. Family history is important. Also, the classic US norm of PSA, turns out in Europe, PSA of 3 is considered abnormal, and that data is probably more accurate. Also, age is really important, because if you look at a 50-year-old, the mean PSA for a 50-year-old is less than 1. And yet somebody gets a 3.8 or 3.9, it's considered normal at 50. It's really very abnormal to have a PSA that level at that age. So these are things that are not well understood by the general medical community, something that would be ripe for computer algorithms or things to highlight. It's like, hey, this is really not right, and be more intensively looking for the fairly rare patients that are going to have more serious cancer at a younger age, but those are the ones whose lives you could dramatically impact by finding it early and taking care of it. And interestingly, I was part of the study that looked back at the physician's health study. So even before PSA became available, there was lots of stored blood of these physicians, 45,000 physicians that were participating in the aspirin study. And we looked back and we took their blood and checked their serum for what their PSAs and saw what happened to them. And it turned out that those men that were in the 90th percentile PSA at their ages were the ones who were accounted for about 80% of the fatal prostate cancers. So even in their 40s, so 40 to 49, median PSA was 0.7. If you were in the 90th percentile, if your PSA was 2 in your 40s, you were one of those people who was, accounted for almost all of the lethal prostate cancer cases. So amazingly important to have more data, to look for outliers early on, and at minimum, screen those people, I think, more thoroughly and carefully, and more of a case that more data is better than kind of saying, let's do it every 2 to 4 years. Just makes no sense. Again, other studies showing just the baseline PSA, if you look 10 years earlier from when a diagnosis was, you can see these rates of rise are really quite substantial. Men are probably already have the prostate cancer. It's been growing and it's accelerating. And you can really start to distinguish who's going to be a problem. So if you look at, these are 60-year-olds, what their PSA was back at 60, and then their risk of prostate cancer death over time can be pretty well predicted from PSA numbers years and years before. So the problem with all of this is that prostate cancer grows really, really slowly. It's taken a long time to show that screening actually saves lives. If you find it early, are you finding it too early and people are having to undergo treatments that may impact their quality of life, long before they really need to? Do you have to repair the whole roof if you see one little hole? At what point is it necessary? These are one of the really challenging questions. So there are some refined tests, some ways to try to sort through PSA. Maybe you're familiar with some. It's called free PSA. There's a prostate cancer health index, 4K score. There's a whole lot of biomarkers that have been used to try to improve the specificity, sensitivity curves over standard PSA, and they have helped. What has really been a huge improvement is MRI scanning. And hopefully, I think there will be more and more data showing that MRI, this is just one showing 4K, even more clearly predicts people who are going to have more serious problem over time. So abnormal 4K score is even more predictive of finding clinically significant cancer, in the decades following these tests. But MRI has been a really revolutionary thing for us. So a couple of things it can do. Here's an MRI showing a normal peripheral zone of the prostate. BPH is, all men get some degree of it. This is what we call the transition zone. So they really are different. Cancers arise in this peripheral zone. BPH is this transition zone, which is really, unfortunately, crowding the urethra and obstructing urine flow. But you can really tell the difference. First of all, if a PSA is abnormal, you find out, oh, the prostate's actually much bigger than you can tell, because you examine the prostate and all you feel is a little bit back here around the rectum, but there can be all of this that's really, really almost impossible to examine, even for a very experienced urologist, to get an accurate estimate of how big the prostate is. Well, what we call PSA density, knowing how big the prostate is, can help you a lot in adjusting how concerned to be about a total PSA. An MRI, the current technology, 3 Tesla magnet, incredibly important in finding some of these subtle early findings of clinically significant cancer. And it's become, remarkably good. This patient has cancer on both right and left in this peripheral zone. And this was the prostate removal specimen corresponding exactly to what the MRI showed. It's made a world of difference to be able to say, anyone with an abnormal PSA, let's sort it out before we do a biopsy, let's get an MRI. What we're able to do is also combine some of these genetic, more sophisticated PSA tests with an MRI to really even be more accurate in making sure that we're doing a biopsy on the right people for the right reasons. So this has become the standard of care in the United States, is that men who have an abnormal PSA or suspicion before a biopsy, they should get an MRI, because the MRI technology has become so important in assessing the overall situation. And when we do a biopsy, we're now using what's called fusion biopsy. So the MRI picture is loaded into the system. We use this system called the UroNav. The ultrasound, which is placed into the rectum and guided by this guidance system, allows us to exactly overlay the image from the ultrasound with the MRI and make sure that we're sampling on a biopsy the exact areas of concern. So this is a typical representation of being able to be really accurately sampling those areas so that we have the best picture of what's going on. So we're not biopsying a whole lot of men that we used to biopsy, because now if their MRI is normal, we have a good explanation for their PSA. They don't need a biopsy, and that's been shown to be very safe. We find now we're really sure, we know that we're dealing with something, we can accurately pinpoint it, make a diagnosis, rather than what happened not too long ago, where we get a biopsy and they don't see anything, but their PSA keeps going up, do another biopsy. Some guys would have 5, 10 sets of biopsies over years before prostate cancer was finally diagnosed. That almost never happens anymore. One thing that we've been doing, and that's been another area that I've been quite involved in, is pushing for what's called transperineal biopsy, which means instead of the needles going up through the rectum, we're going through the skin of the perineum. Much safer, can be done without antibiotics. The risk of sepsis, as we talked about, some of these issues being pushed back of why we shouldn't be diagnosing prostate cancer is because of the risk. This is now can be safely done in the office without antibiotics, good antibiotic stewardship, and the risk of sepsis and infection is almost zero. Also, rectal bleeding, other things that were rare but occasionally serious, just don't happen. Also, we found with MRI, there's a lot more cancers. I showed you the peripheral zone was the backside of the prostate, but it turns out there's actually quite a few more cancers than we really ever appreciated that are on the anterior prostate. And this is a much better way to reach those with the transperineal approach. So that's something that we've been really actively pushing and develop the techniques, and that's basically all we do in our practice, and have done many thousands in this way now. Treatment, there's so many things to talk about, but I just want to give some perspective about some of the best data comes from Sweden about men even 30 years ago were randomized to be treated or not treated for prostate cancer. And again, humbling how slowly a lot of these prostate cancers grow. But if you look at the men who were randomized to have surgery for their prostate cancer versus those that were watched over the decades, you'll see that the men who had surgery, there still can be death from prostate cancer. And I think the problem with the Swedish group is that a lot of them are found pre-PSA, so they were found at a more advanced stage. But the men not treated, you can see that up to half of their deaths were accounted for by prostate cancer. So the men who were treated successfully lived longer, much less likely to have died from prostate cancer. And there really is, as you look over time, a very substantial burden in the men who were not treated definitively for their prostate cancers. On the flip side, we've been doing a lot of work on active surveillance. If you find that there's a very small low-grade cancer, and now we can accurately monitor this, it turns out that over, some of our recent publication is that the vast majority of people over 10 years have been able successfully to avoid having treatment, and the number of metastases is almost zero over 10 years in the patients that are carefully selected by the modern techniques of MRIs, targeted biopsies, really carefully assessing them. Surveillance, not treating patients that have really been carefully selected, can help them avoid these side effects and really is safe. So even in younger men, we did a paper here, even in men in their 60s and below, safely. Well, lots to talk about, and I want to try to wrap up, but modern technology has been amazing. This is what I do most days, is we do robotic laparoscopic surgery where we can very precisely remove prostate and reconstruct everything so that the chance of long-term urinary trouble is really minimal. People are doing great. Sexual function, unfortunately, still, is changed. The prostate makes all the semen, so there are changes. When you find an earlier diagnosis, you can use this technology and expertise to do what we call nerve sparing surgery, so you can preserve the nerve tissue that controls erectile function. We still could do better, but a lot of men are recovering good erectile function and living a very good quality of life with surgery. So the standard operation we call radical prostatectomy means taking the whole prostate out to remove the whole prostate with the seminal vesicles and then reconnect the bladder back to the urethra. Patients stay, some go home the same day, most go home the following day after surgery, recover quickly. This is an operation we're doing, I'm doing 400 a year and people are doing great. It's really a huge difference than what used to be and what colored a lot of those guidelines that told people not to be screened. Radiation therapy is extremely effective, also way of treating prostate cancer. The state of the art is what's called VMAT, which is volumetric arc therapy. So similar to a CAT scan, the treatment is incredibly sophisticated, image guided, and the actual radiation treatment spins. These are just little time slots of it's going around and honing in on the prostate and minimizing the side effects and the exposure of radiation to the other tissues. Super sophisticated. The amount of toxicity and side effects from radiation has dramatically been reduced by this technology as well. This is a huge advantage and another good option. Focal therapy is another area that now that we're finding smaller tumors, there are patients that are appropriate where you can just use various technologies. We call HIFU or cryotherapy. There are various other ways of really precisely trying to killing that tumor with minimizing side effects and damage to surrounding normal tissues. So this is an area of increasing interest. Unfortunately, there's a lot of, I think a pretty small percentage of men actually are good candidates for this, but it's an important thing to consider. And in the right patient, it can be something that can take care of their tumor and really reduce some of the urinary and sexual side effects, which really continue to be the challenges. The bladder, the prostate, the rectum, everything. It's a really tight space. Everything is really close together here, and these are side effects from treatment that the sexual function, obviously very difficult for men and their partners and their sense of well-being. Bladder and bowel function, if that's not working well, people's quality of life is really, really dramatically impacted. And so we have to be very thoughtful, cautious about making sure that we recommend treatment in the right situation and make sure that we do the state-of-the-art best treatments to minimize the side effects of these treatments. So MRI has been hugely helpful. We're doing a lot of active surveillance. So we do screen, and the people that we identify that can be safely watched are being safely watched for long periods of time to avoid these side effects. Unfortunately, PSA testing remains very underused. Only a third of white men and a third of black men over 50 are being tested in the United States. Like that's just terrible. Men of African descent and family history and genetic risk factors should be starting probably at age 45 and screened regularly. This 5-year survival from prostate cancer has really drastically improved with all the technologies and all the understanding that we have. So thankfully, 97% of men diagnosed now are alive in 5 years, which was only 68% in the 1970s. But we've gone backwards. Unfortunately, more and more men are now presenting with advanced disease, and the death rate has gone back up. Again, 70 and older, huge problem. I personally think, now, why not screen men? You got an abnormal PSA, well, get an MRI. If the MRI looks fine, that's fine. It's not a big deal. If you something that looks like a more serious cancer, well, you've got to be selective, as we are with everything else in medicine. Stratify how healthy they are, how aggressive you want to be, and have good conversations with the patients at each level. We have so much good technology. We're not just throwing them into a machine that they can't get out of. At every step, we can counsel them about the pros and cons of the next step and whether it's useful. So it's a huge burden around the world, especially with an aging population. I think with the healthier people live and the longer they live, unfortunately, more and more men are going to be facing prostate cancer. Can be found early. Technology is good. Treatment is good. Success is good, especially when we find it earlier. And treatment does save lives. So really important topic, and been a great honor to be able to chat with you all. And I hope we have some time for conversation and discussion as well.
Well, thank you so much, Dr. Dahl. And I think we have a few questions.
Sure.
So, you know, so I always have this radical question. I think prostate cancer should be totally preventable, just like cervical cancer, right? So cervical cancer used to be the #2 killer for women in the United States. Today, there's very few people die of cervical cancer because we finally understood the HPV was a cause. You can get a vaccine, you can do molecular testing. If you do it, if discover the tumor very early, a simple surgery, can prevent the disease. I think prostate cancer, we're almost getting there. So, and it's really, so what's in your opinion that one day you may not have a job?
Well, that's fine. I think, as I mentioned, the statistics here, that's not likely going to happen anytime soon. But my golf game will be a whole lot better. So
yeah, all right, yeah.
I think this. Can you prevent prostate cancer? When I started, I was one of the first people doing very minimally invasive surgery, so people were enthralled by that. I had people who had bad family history. They said, well, you take off breasts, remove ovaries for people with these bad genetic things. Why don't you just take my prostate out? And I never have done it. But there certainly might be some situations where some men would say, look, let's take the prostate out early if you have really some severe genetic risk factors. If they've had their children or they do sperm banking, I think you can't 100% guarantee people are going to have perfect urinary and sexual function, but they likely would. For some of these young people, the success rate is so good that it's not unreasonable to consider. So I think the challenge is almost all of us. A huge percentage of men are going to get prostate cancer, and most people are not going to die of it. They're not going to suffer health problems from it. And so that's the challenge, is you want to pick out the ones that are going to cause trouble and catch those as early as possible. And we still have a long ways to go in sorting that out, but could prevent it if we took every 20-year-old's prostate out. But
yeah. Well, actually, there's a few questions here. The one question maybe you can answer is it says, my grandfather died of prostate cancer.
yeah.
And my father has prostate cancer now. My father is 66. I have requested to be screened, but my PCP declined to do so. I just turned 37. Why do I need to wait until I'm 40 to be screened? Thank you.
Yeah, I mean, I think the guidelines, no guidelines have said anything lower than 40. But the good news is it would probably be totally normal. And if you can get somebody to order it, the insurance may not pay for it. That's one of the challenges. If you can get some of these tests and pay for them yourselves, and the PSA itself, thankfully, is not very expensive. But there's just so much. Fortunately, I'd reassure you that at 40, your risk is extremely low. But I mean, I don't see any reason why you couldn't have the blood test if it's going to give you some reassurance, and might as well start relatively early and get the test on every year, every other year, and make sure there's no trend of concern. And most men are going to be diagnosed in their 50s, 60s, and the genetically significant ones, we do see people that are, every man in the family has had a serious prostate cancer diagnosis at 50. And those are the ones that are really, worrisome in family histories. There's another question about genetic testing. I mean, I think, the genetic panels have become cheaper and cheaper. I think it's a great idea. I think eventually more and more people will have genetic screening for some of the common risk factors. I mean, I don't know, 23andMe, I think, was doing BRCA screening. I guess they've just gone out of business, but I don't think it's that expensive to have some of the commercially available cancer genetic screening tests done. In Massachusetts, we're required to have you get genetic counseling before testing and after testing, because there are a number of ethical issues and things you might want to think about before you just get the test. Implications for your own family, potential risk for not getting life insurance, health insurance. There's just a number of things that I think it's worth having that conversation and understanding some of those issues before just jumping into it. But eventually, I think most of us are going to have our some of those genetic tests, and those will be automatically that we're going to order those tests when we meet somebody, because they don't cost that much, and it's just actually a saliva test. So just fill a tube with saliva, and so it's an easy test to do.
There's a question here, say, does testosterone treatment increase the risk of prostate cancer?
Well, that's been a big debate. And it turns out when 30 years ago, women going through menopause, everybody said, oh, you got to go through, get estrogen and diminish many of the side effects of menopause. But then later analyses showed that a substantial percentage of breast cancer was probably attributable to that estrogen that was given. Now, testosterone treatment has become very popular. You hear it on the advertised all over the place. The studies so far have not actually shown any significant increase in prostate cancer. All of us have some patients that were kind of clearly taking significant extra male hormones for bodybuilding and so forth. I have a couple of patients that they look fabulous, but they have some really aggressive prostate cancer, and it's hard for me not to believe that there's not some link. But the studies so far haven't really shown a profound link. So my own personal belief is that it should be cautiously used in the right patients, and not at massive overdose levels. Just try to get back to what people would have normally. But I am particularly cautious about treating people with testosterone, and maybe I'm wrong, but it's a huge industry. I do have a sense that it's a lot of people are getting it and may or may not need it. But
yeah, actually, I will share a little bit here. This is all public information. My partner, Dr. Craig Venter, who decoded the first human genome, he actually has very short, CAG repeats on the androgen receptor. So he has very low testosterone in his circulation. So his physician actually gave him, a boost of testosterone. And then a few months later, we saw, a prostate cancer on MRI, and he blamed the testosterone booster for himself because he has such a sensitive androgen receptor. And he think actually that accelerated, the growth, but is totally fine. And, with the MRI imaging. Yeah. So, yeah.
Well, hormone replacement treatment for men is actually very complicated. And you can check someone's testosterone level every 5 minutes, and you're going to get very wildly different numbers. So anyway, I'm cautious and conservative about that myself.
Yeah. So there's a question, say, if you have 1.82 PSA at age 76, what are your chances of developing prostate cancer?
We think that that's a very low risk that you develop significant prostate cancer at that point. So, there have been many studies saying that at 70, if your PSA is less than 4, then your overall chance of developing, and we think we could consider life-threatening or very serious prostate cancer if if we take every 76-year-old and look hard enough, we might find a little bit of prostate cancer, but most of them are not going to go on to have any problem from that. So that's the challenge. We don't want to burden people with a diagnosis that's not really something that's ever going to cause them any problems. So 1.82, thankfully, very low at 76. That's very reassuring.
Yeah. So ask about Lupron treatment. Yeah.
So Lupron, prostate cancer is, as we talked, I think alluded to, and driven by male hormones. So, if you were a eunuch before puberty, you will never get prostate cancer. So you have to have testosterone in your system during lifetime to develop prostate cancer. And one of the first, huge advances in prostate cancer was understanding that if you blocked testosterone, even advanced prostate cancer would regress and become, essentially in remission. And that's still, so Lupron is a way of shutting down the body's production of testosterone. And we use it for men who have metastatic disease. Often it will make it quiescent for many years. I've seen men for 10 years just on the Lupron, even though they had spread to their lymph nodes or their bones. It's not hurting them because the testosterone taken away starves the cancer, and the cancer is not doing anything. We also do use it frequently with radiation treatment. So for certain situations, the nice thing about Lupron is it's an injection that does wear off. So you give a shot, lowers the testosterone level, and then you can just let it wear off. So we can give a specific amount of time of when the treatment is going to be given. So for radiation treatment, it's common to be used to you give the shot, let the testosterone level go down, do the radiation treatment. Has shown in many cases to make the radiation treatment more effective. So that's a very commonly used treatment.
Okay, there's a question from Dr. Keon. If we were to do radical prostatectomy or other procedure on younger men or at early stages, would we expect the complication rate or side effects to be lower in that population?
Yeah, well, in general, yes, I think in general, so for younger, healthier men, we favor surgery. People recover very, very predictably. Their side effects are lower in general. So as men get older, there's more push towards radiation rather than surgery, because there may be more risk with surgery for various reasons, and radiation is very, very effective. So, but yeah, in general, younger, healthier people bounce back faster from surgery. And not to say, I have plenty of men in their mid 70s that are, phenomenal physical specimens that make the 50-year-olds, they don't look any different when they're recovering from surgery. So, expertise in doing the procedure makes a huge difference. Having a great team and experience makes a huge difference. And having, careful evaluation of each patient as an individual, what's the right thing for them. So in general, though, the younger, we favor surgery for younger people also because there are long-term side effects of radiation. So we'd like to avoid those. So if you're in your 50s, and we hope you live into your 90s, there are some new problems that the radiation can cause, even things like new cancer that the radiation itself causes. So we do try to stay away from radiation in men in their 50s and 60s for that reason. If all things being equal, would favor surgery for the younger men. It does keep open the option to do radiation if we need to also. So you're not giving up any of your treatment choices. So
there's a question say, can you discuss HIFU?
Yeah, so HIFU means high intensity focused ultrasound. So this is one of the technologies that's being used for focal treatment, and all of them, the idea is that you can control very accurately high energy instrument to destroy a very specific area. So lasers are used, this HIFU is used, and some of these other cryotherapy, um, irreversible electroporation. There's all sorts of different ways to destroy a very specific area of tissue. And so more and more people are linking these to these MRI pictures so that you can try to, as some of those pictures I pointed out, you find one spot and you can use one of these technologies to kill that tissue, and really minimize any damage to tissues around there. So, there's more and more enthusiasm for that. Unfortunately, most prostate cancers don't grow like one little nugget right in that spot. So in a lot of patients, it's more like one of the ones I showed where we diagnose them, they actually have 2 different cancers in different parts of the prostate. So if you do focal treatment, it has to be, one area, very, very discrete. The biopsies of the normal areas have to be normal. And even with that, the failure rate, the need for additional treatments with focal treatment is substantially higher than it is with either surgery or radiation that treats the whole prostate, because there is likely prostate cancer in multiple areas of the prostate, even if it doesn't show up on the MRI.
There's a question about thoughts on treating BPH using aquablation.
Yeah.
What is a
BPH? No. Yeah, aqua ablation. So BPH is benign prostate enlargement. That's the tissue that grows in the urethra and blocks the urinary channel and causes more and more urinary symptoms as we get older. And so medications can help manage those symptoms. There are a number of different surgical procedures that reduce and take away that tissue. So aqua ablation is one of the newer ones that uses some computer guided imaging of sort of actually use these water jets to kind of cut away the abnormal tissue. And so, yeah, some I don't do them. Some of my colleagues here have been involved in that, and like a lot of things that they're very specialized. So a few people get very, very good at them. How generalizable they are to different communities can be a challenge. So in the really expert hands, some of these things look fabulous. As they kind of, somebody in a community says, "Oh, that looks great, I'm going to try it," they may have a lot more trouble. So you have to be very careful about that.
Yeah. Actually, in the because we're running out of time, and our video will be on HLI's website, I believe. And I will just say a few things. Human longevity has been around for 12 years, and we are the very few company combines genetics, whole genome sequencing, clear-capped whole genome sequencing with whole body MRI, with unique software like ISI to look at prostate. We do, metabolome protein marker testing. And some of the clients, we have followed them for over 10 years now. I think my partner is the first prostate cancer patient we discovered out of,
Wow.
Craig, so we have, I think out of 5,000 men, we discovered about 60 some people has, various stage of prostate cancer. So, we are constantly improving our algorithm. For instance, we are putting like androgen receptor into a polygenic risk score. There are other genes we really pay attention to, like the HOX13B, which apparently makes the cancer much more aggressive. So doing genetics, in my opinion, is very important. So there's, so you can even potentially in the future predict which cancer will grow faster, which one will grow relatively slowly. And obviously imaging is fascinating, so some of the algorithm we use can even give you Gleason stagings using MRI imaging. And then, we're also doing proteomics on, on blood. So, I think we're getting closer and closer to what I call the elusive goal of, a test or a series of tests will get to 100% sensitivity and 100% specificity. So, we committed $1 million for every one of our member who is willing to join this kind of phase 3 clinical trial, not to die from prostate cancer. So in case we missed your stage 4 prostate cancer, we can always call Dr. Dahl. Okay, so and we have a network of wonderful, wonderful physicians. And I actually think knowing where to go, what kind of intervention to do, sometimes make the huge difference. I always say, Mike Malkin was was diagnosed with late stage prostate cancer when he's in 1993, but he's a billionaire. He dedicated over $100 million to treat his prostate cancer. He's live and kicking, 30 years later. So, having access to the knowledge, the intervention, and all the bleeding edge, kind of knowledge, I think, we are on our way to, control this disease. Thank you so much.
We've made huge progress. We have a lot more to go, but it is very hopeful. And the technology and the understanding of the biology is phenomenal, and one of the exciting things about being in this area.
Yeah, no, it's we're hoping that our 30-year clinical trial data shows that if you come to our clinic, we do all these things and team up with Mass General, and all that. Very few men should die of prostate cancer. That's kind of our commitment. Yeah.
Great.
Yeah. Thank you so much. Thanks everybody for joining the the webinar, and thank you so much.
Have a good night.
Bye-bye. Bye-bye.